This is the last part of the video series on head impulse testing. Part 4 describes the application of VHIT through a series of clinical examples and provides a comparison of VHIT with other vestibular function tests. VHIT offers several advantages over the traditional vestibular tests. First, it allows us to evaluate all three semicircular canals and their neural pathways in each ear independently. Abnormal findings have a high degree of specificity and can localize the lesion to the involved semicircular canal or its afferent neural pathway. The test is suitable for serial testing and can be used to track changes in the VOR function over time. VHIT can be used in children as long as the goggles can be fit properly. The entire test can be completed in less than 15 minutes, and because the equipment is portable, it can be used in inpatient, outpatient, and emergency room settings. The Coloric test has been the primary method for identifying peripheral vestibular lesions for many decades, so it is important to understand how VHIT compares to the Coloric test. First, both tests can identify site of lesion, but the Coloric test is limited to evaluating the lateral canals and their neural pathways, whereas VHIT can provide information about all 6 canals and their neural pathways independently. Second, caloric stimuli are equivalent to very low frequency head movements, whereas VHIT tests the canals at higher frequencies that are more compatible with the operational range of the VOR. Third, caloric stimuli are not calibrated. Although the stimulus parameters are controlled at the ear canal, the temperature gradient that reaches the labyrinth is highly variable. As a result, the response is different from one person to another and from one time to another. Also, the caloric test is time-consuming, and the stimuli are unpleasant to most patients. On the other hand, the stimulus in VHIT can be precise, well tolerated by most patients, and the test takes only a few minutes to administer. Finally, the equipment for VHIT is portable, whereas the caloric irrigators can be bulky. Despite its limitations, one should remember that the caloric test has had a long history of being the most useful test of peripheral vestibular function, and that VHIT has been gaining widespread clinical use only in recent years. So for the time being, VHIT should not be considered a replacement for the caloric test, especially because they represent different ends of the frequency spectrum. Also, VHIT may not be very sensitive to mild unilateral lesions, although we do not yet know exactly what the threshold of the asymmetry is for abnormal VHIT. Some of the studies that have tried to establish this limit may have relied only on the VOR gain, which, as it was discussed in part 2 of this video series, is not the most appropriate approach to the interpretation of VHIT results. When compared to the rotation chair test, VHIT offers a number of advantages. The rotation chair test is limited to testing both lateral canals simultaneously, whereas VHIT can test all 6 canals independently. The stimuli for the rotation chair are very precise and repeatable, which makes the rotation chair suitable for serial testing. VHIT stimuli are also adequately repeatable and precise for serial testing. The rotation chair covers low to mid-frequency head movements, whereas VHIT operates at high frequencies. Rotation chair testing requires large space and the equipment is expensive. VHIT, on the other hand, is portable and relatively inexpensive. The rotation chair test has been considered the gold standard for identifying bilateral vestibular loss and for documenting its severity. As we discussed in part 2, VHIT can provide similar information for bilateral vestibular lesions, but unlike VHIT, the rotation test is not as effective for unilateral vestibular abnormalities and for identifying the site of lesion, because the chair velocities are usually not high enough to create VOR asymmetries. In view of the advantages of VHIT, the clinical value of the rotation chair is expected to diminish as VHIT becomes more widely used. When VHIT is compared to the active head rotation test, also called high-frequency VOR test, there are some similarities and also major differences. Both tests can evaluate lateral and vertical canals using high-frequency stimuli, but active head rotation cannot provide information about the site of lesion. Both tests can provide information about bilateral vestibular loss, but because of the voluntary nature of the stimuli, the results from the active head rotation test may be contaminated by the activation of neck receptors. Considering the differences and similarities between the two tests, VHIT can effectively replace and provide additional information not available from the active head rotation test. This slide shows a comparison of the frequency ranges for different vestibular tests. Natural head movements cover frequencies of about 0.05 Hz up to 3 Hz. For these frequencies, the VOR gain is approximately equal to 1, and the VOR produces completely compensatory eye movements. The rotation chair test covers frequencies that are at the low end of the natural head movements, whereas the active head rotation covers frequencies that are at the higher end of natural head movements. The head impulse test roughly covers the same frequencies as the active head rotation. The approximate frequency for the Coloric test is considerably lower than all of the other tests. Let's review how VHIT can be incorporated into the protocol for evaluation of dizzy patients. For each of the items on this list, a clinical scenario will be presented later to elaborate on the application of VHIT. VHIT can be used as the first vestibular test for patients suffering from dizziness and vertigo. In an emergency room setting, VHIT can be used as one of the tests to differentiate between stroke and vestibular lesions in patients with an acute onset of vertigo and associated symptoms. In the outpatient clinic setting, performing VHIT can reduce the time and cost of arriving at the final diagnosis. When combined with ocular and cervical vestibular evoked myogenic potentials, or VEMPs, VHIT can provide a complete evaluation of each structure within the labyrinth and its afferent neural pathway. VHIT can be used to monitor changes in the VOR function over time as the patient undergoes treatments that require administration of vestibulotoxic medications, such as in chemotherapy or in gentamicin treatment for the Meniere's disease. VHIT can also be used to monitor recovery, such as in cases of vestibular neuritis. Another application of VHIT is in evaluating the VOR function before and after procedures that may damage the vestibular structures, for example, in case of surgery for vestibular schwannoma or in case of cochlear implantation. Finally, VHIT can be used to evaluate patients with suspected bilateral vestibular loss. Here's a sample protocol of how VHIT can be used in evaluation of dizzy patients. History and physical examination are always the first steps in the process. According to the American Academy of Otolaryngology, patients suspected of BPPV do not need to undergo full vestibular testing. The use of VHIT is not necessary for these patients, but it can be used as an adjunct, especially for patients who develop BPPV after a vestibular abnormality such as Meniere's disease or vestibular neuritis. If after 2 or 3 attempts the repositioning maneuver is unsuccessful, the patient should undergo a full evaluation. In patients who undergo the full vestibular evaluation, performing VHIT first allows one to predict the results of the Coloric test and even reduce the number of irrigations. Adding ocular and cervical VEMPs here can provide a complete assessment of the vestibular structures. The rest of the protocol includes VNG and other tests that are typical in the evaluation of dizzy patients. Now let us consider a few clinical scenarios. The first case is a patient who comes to the emergency room with a sudden onset of vertigo and associated symptoms. The main question in this patient is to determine if the patient is suffering from a vestibular event or from a stroke. Newman Toker, Kata, and their colleagues have developed a guideline based on 3 simple tests. These tests are identified by the acronym HINTS, or HINTS. HI stands for head impulse. N stands for nystagmus in right and left eccentric gaze positions. And TS stands for test of skew. The last test involves looking for vertical misalignment of the eyes by alternately covering each eye. When a patient with acute vertigo has normal head impulse test, nystagmus that beats in different directions in gaze right and left, and has skew deviation, there is high likelihood that this patient is suffering from a stroke. Interestingly, within the first 48 hours after the onset of a stroke, this approach has been reported to have slightly better sensitivity than MRI, 99% compared to 95% for MRI. That's because the structural changes are sometimes missed in the early stages of stroke. Obviously, VHIT plays a significant role because evaluation of the head impulse test results requires identifying both overt and covert saccades. The second case involves a patient whose symptoms match those of vestibular neuritis, but the Coloric test shows no abnormality. In this case, VHIT can help with identifying rare cases of neuritis that affect the inferior portion of the vestibular nerve. Even when the Colorics are abnormal, VHIT can determine if the lesion is limited to the superior portion of the vestibular nerve or involves both branches. Patients whose lesion is limited to the superior branch are at a higher risk for developing secondary BPPV because the pathway for the posterior canal is still intact. VHIT can also be used in vestibular neuritis patients to determine if the lesion is improving and if the function is returning to the damaged nerve. In patients who are treated with steroids, VHIT can evaluate the effectiveness of the treatment. Finally, in conjunction with ocular and cervical VEMS, VHIT can provide a complete evaluation of both branches of the vestibular nerve. The lateral canal and the superior portion of the vestibular nerve in the irrigated ear are involved in the Coloric testing. The same pathways are also tested during ipsilateral head impulses. And finally, the lateral canal and the superior branch of the vestibular nerve in both ears are involved during the rotation test. The anterior canal and the superior portion of the vestibular nerve are involved during downward head impulses with the head turned away from the test ear. The posterior canal and the inferior portion of the vestibular nerve are involved during upward head impulses with the head turned toward the test ear. Air-conducted cervical VEMS recorded from the ipsilateral neck muscle are considered to be a test of the saccule and the inferior branch of the vestibular nerve. There is still controversy and uncertainty about the origin of the ocular VEMS, but when recorded from the contralateral eye muscle, they are most likely a test of the utricle and the superior branch of the vestibular nerve. This table demonstrates how a combination of VHIT and VEMS, both ocular and cervical, can provide independent evaluation of all structures within each labyrinth. Again, we're assuming that the pathways mentioned in the previous slide are indeed the pathways that are evaluated in these tests. A lesion in the lateral canal is expected to produce abnormal VHIT findings for lateral head impulses toward the site of lesion. All other tests are expected to be within normal limits. For anterior canal lesions, downward head impulses are expected to be abnormal with the head turned away from the site of lesion, while all other tests should be normal. For posterior canal lesions, upward head impulses with the head turned toward the side of lesion are expected to be abnormal. All other tests, again, should be within normal limits. For focal lesions of the utricle, ocular VEMPs recorded from the contralateral eye muscle are expected to be abnormal, and for saccular lesions, cervical VEMPs recorded from the ipsilateral neck muscle are expected to be abnormal. VHIT should be within normal limits for both utricular and saccular lesions. For abnormalities involving the superior portion of the vestibular nerve, the findings will be a combination of the findings for different structures that share that branch of the vestibular nerve. Those are the lateral canal, the anterior canal, and the utricle. For the inferior branch of the vestibular nerve, the abnormalities are expected to be a combination of the findings for the posterior canal and the saccu. This table demonstrates that VHIT, in combination with ocular and cervical VEMPs, has the potential for changing the approach to the evaluation of vestibular disorders. An interesting related case is when the symptoms mimic vestibular neuritis and all of the vestibular tests are consistent with neuritis involving the superior branch of the vestibular nerve, except for ovens, which are not abnormal as expected. These findings collectively point to the presence of focal lesions in the lateral and anterior semicircular canals. The patient most likely is suffering what has been termed anterior vestibular artery syndrome. This is a condition that's caused by ischemia involving the anterior vestibular artery. The next case involves a patient who is diagnosed with Meniere's disease and is scheduled to receive intertympanic gentamicin injections. The current protocol for termination of injections is based on the results of the serial hearing tests. VHIT can be used for serial testing of these patients to monitor the VOR function over time. In fact, the test can provide information before and after any procedure that can change the function of the vestibular system, such as chemotherapy, surgery for vestibular schwannoma, or steroidal treatment for neuritis or Meniere's disease. The next clinical scenario involves a child who is scheduled for cochlear implantation. VHIT can determine the status of both labyrinths before implantation and determine the preferred side when the implant is planned for one side only. After the implantation, VHIT can again provide information about the post-surgery status of the labyrinths. Finally, the last case involves a patient who has bilateral caloric weakness. This patient must undergo a second test to determine if the finding represents a true bilateral loss of function or if it is a false positive finding caused by heat transfer issues in the caloric test. Traditionally, the rotation chair testing was used for this purpose, but as we saw in part 2 of this presentation, the same information regarding the presence and the extent of bilateral loss can be derived from VHIT at a considerably reduced cost, time, and space requirements. The main contraindication for performing the head impulse testing is presence of neck problems. Usually patients with mild neck problems have no difficulty with VHIT if the test is performed correctly, which requires small amplitude, high velocity head movements. Because the recordings are made from the right eye, patients with prosthetic right eye or those with severely limited range of motion cannot be tested. Also, patients with certain oculomotor abnormalities, such as saccadic slowing or internuclear ophthalmoplegia, may have unusual findings in VHIT because of the change in the velocity profile of the catch-up saccades. In summary, VHIT is a simple and quick test of the VOR function that can provide objective and independent assessment of all 3 semicircular canals in each ear. VHIT can be used as a first step in the evaluation of dizzy patients because it can reduce the need for unnecessary tests and can provide a cost-effective approach to the diagnosis. VHIT is suitable for serial testing and can monitor changes to the VOR function over time. For more information and updated news regarding ICS Impulse, please visit ICSimpulse.com. For update on recent publications and scientific information about the video head impulse testing in general, please go to headimpulse.com. If you have any questions or comments regarding this video series, please post them to the blog on headimpulse.com.